Very good evening, dear friends. I welcome you to this webinar question and answer session on, uh, laser. Very good evening, dear friends. I welcome you to this all to this question and answer live session on laser physics basics principles. As you heard in my lecture on the webinar, we spoke on the laser basics, the principles, and the laser tissue interactions, and we spoke on the various wavelengths, the chromophore, the thermal relaxation time, and the various parameters that one follows while conducting laser sessions in our clinic. The present question and answer session actually aims at the practical implications of using aesthetic lasers in our clinic. The aesthetic work that we do in our clinic entails treatment of pigmentary conditions, rejuvenation, texture, hair reduction, and other indications. So, when we select our patients for laser sessions, the most important and the key point that we need to remember that we deal with a skin of color. So our Indian skin has various shades of brown, and the Fitzpatrick type of skin that we deal is around type 3 to type 5. So for this kind of skin, which has a lot of epidermal melanin and very rich melanosomes compared to type 1 and 3 skin, we have to be very careful with the laser parameters that we choose. We have to be very careful with the systems that we invested, and we have to be very careful with the outcomes that we give our patients, because there is risk of pigmentary sequelae with the wrong parameters in our patients. Now, in the aesthetic practice, when we select laser for any indication, may it be for hair reduction, or may it be for pigmentary conditions, or may it be for textural improvement, rejuvenation, wrinkle reduction, we need to first identify an indicated patient for the procedure. So, how do I choose the patient for aesthetic procedure? So, first of all, there should be a standard indication for the procedure. Second is you need to understand what the patient desires out of the procedure. Thirdly, we need to understand what is the cosmetic or aesthetic outcome we can achieve for our patients, and what are the outcomes we can promise our patients. Fourth is we have to identify any risk factors associated with choosing these patients for procedures. For example, when you conduct a laser hair reduction on a very tanned skin, and your pulse duration or your parameters uh, 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 contains very high energy and short pulse duration, you may end up resulting in epidermal uptake of the laser energy and create epidermal blisters or burns, which is a untoward or a undesirable side effect for the patient, and you may lose the patient to an aesthetic indication which you had not predicted. So choosing an appropriate patient is very important. Once an appropriate patient is chosen for a laser indication, clinically you have to identify whether the patient has a short-term deadline or a long-term routine lifestyle. If there is a short-term deadline, you have to be very careful in choosing your parameters, because priming is very essential in the type 3 to 5 skin, especially type 5 skin. If you take them up without any priming of the skin, then your risk of side effects will get very high. So, in my clinical practice, I divide these patient choices into whether I'm doing a procedure for a short-term indication or whether I'm conducting the procedure for a routine life for a patient. Once the skin type and the indication is identified, and I know my time span for this patient, whether I have to achieve an outcome in 2 to 3 months, or whether I have to achieve an outcome in a month, or whether I have to achieve an outcome over 6 months to 1 year, and then I would start priming my patient. In priming my patient, the first thing I would do is choose a broad spectrum sunscreen. The current choice for broad spectrum is more broader than broad spectrum in the sense that we should choose a sunscreen filter which covers not only the UVA and the UVB radiation, but also covers the high energy visible light or the blue light, which we all know are the LED and the electronic screen monitors and the cell phone lights that our patients come across. So, the first step to good priming before a laser is an absolutely sun protected skin and a very compliant patient. Second criteria for priming is if you're doing a laser for pigmentary reduction or rejuvenation or laser hair reduction, you need the epidermal pigment to be toned down. So this tone down of the epidermal pigment can be done with pigment lightening creams, and for textural improvement, textural enhancing creams can be used. So normally my criteria for choice of a priming agent would be a lightening agent like a kojic acid or an R-butene based cream. I tend to uh, prevent hydroquinone based creams when we are very close to the date of the procedure, and tend to withdraw the irritant creams at least a week before the procedure. I can use retinols or adapalene as a priming agent when I choose lasers for my acne patients, or I would use a glycolic acid and vitamin C based creams when I choose my patients for textural improvement. And a combination or rotation of priming agents helps you to prepare the patient well. I also, on the day of the procedure or when I plan a laser session for my patient, I would look at the pigment sign or the sleeve sign to check for tan skin or a recent tan, and I would also look at the palmar creases for any hypopigmentation. Yes, so there's one question from Vivek Singh. Which laser is best, IPL, diode, LX, or NDX? So this is a long drawn debate. The IPL is a broadband light, whereas the diode, LX, and NDX are the true lasers. While the diode and the Alexandrite lasers are comparatively shorter wavelength, they have a better absorption into the chromophore, that is the melanin in the hair shaft and the bulb and the bulge. So they are considered a little bit superior over the NDAG. But all said and done, we have large number of practitioners in the country who are using NDAG, which is a longer wavelength. And because longer wavelength means more deeper absorption, so the deepest hair can pick up this laser wavelength and can absorb it well. And because the NDAG has very minimum absorption into the epidermis, the risk of side effects when you're dealing with type 5 to 6 skin, or you're dealing with a patient who has had a recent tan and you still need to conduct a laser hair reduction because of the short deadline, then using an NDAG is a great idea. The NDAG, though it has a deeper penetration, is a little bit painful compared to the diode and the alexandrite. I currently I am using a diode laser, and I have been using the diode since more than 20 years now, and I find it a very nice wavelength to work with when you're dealing with laser hair reduction. There are various kind of systems available. A good system to have is a system which can give you a short spot, a small spot size along with the combination of a long spot size. This enables to treat your smaller areas as well as treat your larger areas very well. Like for example, in a system which has a large handpiece, the one which I have has a large spot size of 7.5, which enables me to treat arms, backs, chest, and legs much more faster. Whereas at the same time, I can shorten my spot size to a very small, say 2.5. And this helps me to treat small areas like the upper lip, chin, jawline, neck. And also, many of the systems nowadays have an external adapter. Uh, and these adapters help us to treat very small areas which are not accessible by standard tips. So these adapters can treat very small areas like the corners of the lips or the angle around the nose, or even the external auditory canal, or the hair on the ear. So that is about the choice for laser. Intense pulse light, because it acts like a platform where you can change your filters, and the filters for intense pulse light are available between 500 nanometers to 1100 nanometers, and you can use a cutoff filter and conduct a laser hair reduction. So many people are comfortable with the intense pulse light. But I have large experience on the diode, so I can vouch for the results of diode laser. Uh, Recently, the newer technologies in the diode laser have one which is called as a linear scanning diode laser, where a very small beam of 1 millimeter passes through the skin, and this beam has a good depth of penetration, and with a small or a large spot size, you can scan a 50 millimeter area just in one go. So you can cover large areas, and the procedure is actually painless. So we are looking at, as clinicians, when we want to achieve hair reduction in our patients, what we look at is optimizing outcomes. We need to convert terminal hair into vellus, or at least obtain 60 to 70% of hair reduction in our patients. And we need to be safe for the dark skin types. We cannot land up with pigmentary sequelae, and we need to do the optimum number of sessions in our patients, because the patients look at a timeline for these sessions, and the average number of sessions I end up doing with my diode in a standard indicated case is around 12 to 13 sessions, where I would conduct typically 6 to 7 sessions in the first year, and 2 to 3 sessions in the second year. Of course, I investigate the laser hair reduction patients completely, and in indicated cases where I suspect hyperandrogenism, I would run their hormone profile test before I take up the laser. And along the line of the treatment, after a couple of sessions, say 3 to 5 sessions, if I feel that uh, the hair reduction is not up to the standard, then I would reconduct the hormonal test in between, to find out if there is an active blood parameter of hormonal influence which is not allowing the hair to reduce. So these are the patients which need thorough investigation. As far as the improvement of texture with the help of laser, so there are two types of lasers available: ablative lasers and non-ablative lasers. The In the ablative lasers, which were used more than a decade ago, where you ablate the epidermis, and then you rely on the regeneration of the epidermis, and collagen shrinkage by the residual thermal damage from the laser heating, can give a very good improvement in texture. Over more than last 10 years now, the ablative lasers have been replaced by fractional ablative technology, where you, instead of creating robust and bulk heating of the tissue, you create a micro thermal heating and minimum residual damage, and the heat shock protein and the collagen shrinkage and the collagen denaturation can be achieved with minimal crusting of the skin. And here you are only partially ablating the skin, so there is a very less downtime compared to the ablative modalities of laser. So in skin type 3 to 5, when the ablative laser resurfacing with the erbium or the carbon dioxide was done, there was a lot of pigmentary sequelae. So globally, we have now replaced it by fractional resurfacing technology, where both the carbon dioxide laser, which with its 10,600 nanometer wavelength, and the erbium YAG, which is 2940 wavelength, is very good for resurfacing. The resurfacing procedures that we do with these two wavelengths are generally acne scars, non-traumatic scars, non-acne scars and surgical scars, and also for wrinkling and textural improvement and improvement of open pores is helped by these procedures. When we use the fractional ablative resurfacing technology, our main concern is that we cannot land up with a pigmentary sequelae in our patients. So we tend to use long pulse durations, and we tend to use less aggressive parameters. Hence, our treatments get repetitive. But with the advent of transepidermal drug delivery system through these laser channels, when we do a fractional erbium or a fractional carbon dioxide, there is a transepidermal gradients which is created, and we can deposit a lot of medications to enhance the skin. So the common deliveries transepidermally that can be done and are time tested and are evidence bases, platelet-rich plasma, certain growth factors, vitamin C, hyaluronic acid, repair creams, emollients can be deposited after resurfacing procedures. Which other tattoos can be treated with Q-switch Nd:YAG? Dr. Rajayan has been asked. So the Q-switched Nd:YAG the best indication for tattoos is amateur tattoos, and the carboning tattoos are best treated with the Q-switch Nd:YAG laser. As we all know that the two common wavelengths used are the 532 frequency double, which is used for red color tattoos, and the 1064 wavelength, which is used for carbon ink tattoos, which can be treated. As far as the green and teal or purple color tattoo, they are more amenable to uh, wavelengths of the pico laser, which is available, which fires into the skin in the picosecond range, and they are more amenable to the pico lasers. The Q switch lasers, the quality switching technology creates a very ultra short pulse in nanoseconds. So very high energy beam is generated. As we know, melanin, the size of melanosomes is very small. So the thermal relaxation time is rather than picoseconds. What we use is a nanoseconds laser. So we create a blast effect of the tattoo ink under the skin, and this tattoo ink is then eliminated, and it's resorbed through the macrophage system and eliminated through the lymphatic system over time. There are two kinds of studies which have done for gauging the optimum outcome for the tattoo treatments. One is that the conventional technique is where you conduct one session every 3 or 4 months apart, and this conventional technique has reported that the outcome is better if you give adequate time between conducting a Q-switch Nd:YAG tattoo removal and waiting for the next session. Uh, but as we know, sometimes the patients have short deadline and they desire faster treatments. So treatments as short as 6 weeks has been done. There are two new ways in which the Q-switch Nd:YAG laser has now been used to remove tattoos. One is the R20 method, and second is the R0 method. Uh, there are papers on the same, and in the Journal of Cutaneous and Aesthetic Surgery and international journals has been reported by Dr. Swapnil Shah and Dr. Sanjeev Aurangabadkar, who are Q-switch masters in our country, as we all know, and we've read their papers where they have reported optimum outcomes with the R0 technique and the R20 method. In the R20 method, you do the Q switch laser session with the conventional energies, and this is followed by a 20 minutes gap in which you wait for the frosting to disappear. That is the gases which are generated during the laser Q switch laser technology. You wait for the frosting to disappear, and then you fire a second round during the same session where you reduce 20% the energy by 20%, and then you fire a third round. There are because we still deal with the Indian skin types with the standard R20 method, and 3 passes done over 60 minutes have reported some degree of side effects like pigmentary sequelae and scarring. So in the modified technique, most of the Indian experienced tattoo laser users or experts use only two passes 20 minutes apart. Compared to that, in the R0 technique, you can use a particular liquid called as perfluodecaline, and this is applied on the skin immediately after the tattoo laser treatment, and wait for about 2 to 3 minutes, and then you can fire a second round of the laser on the tattoo without waiting in between. So because there's no waiting period between the sessions, it is called as the R0 technique. And the end point of this laser is generally a frosting of the skin with a very high fluence and a very small spot size. You can also get blistering in the area. You can also get a little purpuric tinge to the skin on this area after you fire the skin with the Q switch laser. Also, the Q switch laser has a lot of expanded applications, and in the last 5 to 7 years, the Q switch laser has come on the top of the list for our younger generation of dermatologists when they plan to buy a laser. The reason for doing this is that we deal with a lot of pigmentary indications in type 3 to 5 skin. These pigmentary indications range from post acne pigmentation to active acne to pigmentary conditions like freckles, melanocytic nevi, then nevus of Ota, so congenital nevus disorders, congenital nevoid conditions, and acquired conditions, even like melasma, which is expressed highly in the Indian skin type, uh, from melasma to all the pigmentary conditions on the skin are treated with the Q switch laser. So the current Q switch lasers that we are using in India, and also uh, they are time tested and evidence based, is where you use the standard Q switch method and you use the advanced Q switching technology. In the advanced technology, you have two advances. One is the expansion of the principle of selective photothermolysis to a higher principle called as um, subcellular selective photothermolysis, where you use a larger spot size, comparatively 8 millimeter to 10 millimeter, and you use the laser toning technique where you use a low fluence and a large spot size, so the depth of penetration is good. With this subcellular selective photothermolysis, what you do is you are not killing the melanocytes. If you kill the melanocytes, you destroy the melanocytes, there'll be regeneration of melanocytes, and regenerating melanocytes can also cause total destruction of melanocytes can cause hypopigmentation or depigmentation. Partial destruction can cause reactivation of melanocytes. These reactivated melanocytes can in turn give rise to post-inflammatory hyperpigmentation. This happens with conventional parameters. Compared to that, if we use non-conventional or advanced parameters with a low fluence laser toning, you can cause dendritectomy of the melanocytes. And this dendritectomy enables good clearance of pigment because you are preventing transfer of melanosomes from melanocytes to keratinocytes. And also, you can use an external chromophore like the carbon lotion, which is a suspension of 40 microns of carbon in a little bit of an oil base. And it acts as an external chromophore because we know the Q switch wavelength has high absorption into the dermis, but it has a comparatively less absorption into epidermis. So when we see a photo damaged skin with a particular degree of epidermal pigment, which can be tracked through dermatoscopy, and you want to target that pigment, you can use an external chromophore like carbon lotion, and it can help to create a photo rejuvenation. The same carbon ink also settles in the same carbon suspension settles in the pilosebaceous units, and it can be used very beautifully to treat inflammatory acne. So, can we use fractional carbon dioxide for keloid? I use the fractional carbon dioxide for keloid. Here I do not, because very, very high energy can stimulate, collagen. So here, when I use a fractional carbon dioxide for keloid, I generally use it to create transepidermal channels for deposition of uh, steroids, or for deposition of 5-fluorouracil, which sometimes I don't inject it. I use 5-fluorouracil as a paste on the keloid if the keloid is small enough and non-bulky. So I use a fractional carbon dioxide for keloid very much. The fractionated mode is that you are creating microthermal zones, but there is a gradient for transepidermal absorption. So after that, whatever you deposit into the skin gets absorbed. So the conventional mode is to use an intralesional steroid injection with intralesional 5-fluorouracil. But in certain indicated cases, like acne keloid Ellis, for acne keloid Ellis on the jawline, when you're using a laser for the rest of the face, your parameters have got to be optimum, and you cannot cannot stimulate collagen. That is the idea. Your certain heat energies are used for lysis, and in here you need to achieve lysis. The fractional microneedle RF is being used for the keloid, and if you can if you can deposit intralesional radio frequency in the keloid. So my early experience, and also experience of other experts in our country, where it's been used for the fibrotic scars, and for hidradenitis suppurativa in the axilla. So energy-based devices, because they are chromophore blind, are getting more popularity. When I was talking of the expansion of the horizon of the Nd:YAG laser, for all the time we focused on the wavelength of 1064, and we really love this wavelength because it is so Indian skin friendly and it can do so much for our pigmentary patients with the Q switch Nd:YAG. So a little expansion is in this technique is, instead of using the nanosecond pulse, there is a 300 microsecond pulse, which makes this 1064 wavelength into an sort of a non-ablative laser for rejuvenation. So it is also called as a Cossi pulse or the revital mode of laser, which works beautifully. Studies have shown that the 1064 microsecond pulse lasers have high affinity for absorption in the sebocytes. They reduce seborrhea on the surface of the skin. At the same time, they reduce the open pores, and so there's a lot of textural rejuvenation. The only word of caution with the revital mode of laser is that it can enhance a little epidermal pigment, so your patients got to be well primed. And what I do in my patients is I do a round or two of laser toning with the 1064 QS wavelength before I fire the microsecond pulse on the skin. Typically, about an energy of 2000 to 3000 should be deposited on the face and neck, and it gives an excellent textural rejuvenation. Another expansion of the laser toning mode is called as the QTPT mode, where you break the subpulse. If you want to use a high fluence, but you don't want the high fluence to cause any sequelae, you can break the pulse into two subpulses, and that way you are not allowing the target to be you allow the target to be heated well, because the space between the two subpulses is very, very small, but you are allowing a good effect with minimum side effects. Another expansion of the wavelength as the 1064 wavelength is converted into a, 660 nanometer also, because this wavelength is equal to the ruby laser, which is so the 660 is called as the ruby wavelength, and it is used to treat freckles. As we know that the frequency double 532 nanometer wavelength is used to treat freckles and lentigens. Because of that, when you're firing freckles and lentigens, if you're using a 532, the only robust fear we have while we treat with 532 wavelength is PIH, or side effect with hypopigmentation in the area if your energy has been too high. So compared to that, a 660 wavelength is good for epidermal pigment, but it has less chances of pigmentary sequelae. Dr. Rajan, thank you. You have asked me a question. A female comes with grade 4 acne and her marriage next month. How will you approach? Yes. So, grade 4 acne with a short deadline. So, obviously, we have to refrain from oral isotretinoin. Some people do not like to use low dose steroids to bring down the uh, oral steroids to bring down the inflammatory acne, and they do not want to do anything regarding hormones because their marriage is coming up. So after ruling out any medical issues in the patient and after putting on baseline acne defining protocol, Global Alliance outcome to improve in acne, if you are thinking of a laser intervention, two very good approaches to a grade 4 acne would be largely inflammatory papulonodular pustular acne. One is you can consider doing a Q switched gold toning laser. So some of the NDAG systems have they have a platform where you can have the 1064 wavelength is modified by a particular rod dye which is called as the gold toning wavelength, which is 595 nanometers. This wavelength, because it is a short pulse for vascular affinity, so it has absorption into hemoglobin and methemoglobin, but it is not a long pulse, so it can have a photobiomodulatory action on the blood vessels. So if in such a patient, I would combine a carbon laser toning. So the carbon lotion is applied, the carbon lotion settles into the pilosebaceous units, and after that you use a laser toning wavelength of 1064 and blast off the carbon. So this carbon laser toning helps to bring down the inflammatory acne drastically in just a span of around 8 to 10 days, and or you can use a Cosy pulse revital mode of the laser 1064 wavelength in 300 milliseconds, and this is followed by the gold toning wavelength, and the combination approach helps us to bring down inflammatory acne. So this is how I would approach a grade 4 acne marriage next month. I would do an average of maybe 2 or 3 sessions done around 10 days apart. And the last session can be done around 3 to 4 days before marriage. The laser toning wavelength in this helps to improve the pigmentation a bit. And for these patients with grade 4 acne, they are very, very happy if you just bring down their active acne and reduce it substantially during the treatment. Another option available for the grade 4 acne patients is you can consider the red light and the blue light treatment. They are not a true laser, and you use a wavelength between 400 to 700 nanometers. So the red light is around 500 nanometer, and the blue light is 513 nanometer, and the red light is around uh, 613 nanometer. And you can give a combination of the red light and blue light. There are many studies which show that active acne can be brought down by red and blue light, and a combination of both should be used. In my clinic, I use a 15 minutes of red and blue light, and this can be done little more frequently. There are studies which show that you can do it twice in a week. So if you have 1 month before her marriage, you can do 8 sessions in between bi-weekly. But if you're doing a standard laser like a Cosy Pulse Revital or a laser toning, carbon laser toning, then you have to space it at least to 10 to 12 days apart. And uh, so, Omkar, do we have any more questions? Okay, so before I wind up, one word of caution that in case while you are conducting lasers, most of the lasers I understand it's pigmentary lasers, lasers for texture, laser for rejuvenation. Whatever the lasers that we use, they are for aesthetic purposes. So we should observe and critically analyze the patients in between the session. Look for any unwanted pigmentary sequelae or any unwanted there are like small indicators. For example, when you use carbon lotion laser toning for a patient, there is, because the carbon suspension is made in a little oil, so it can give rise to a very little acneiform eruption seen 3 to 5 days after the laser procedure. So you have to be available to the patient, you have to be accessible to the patient, you have to understand and identify your side effects, something as simple as epidermal burns caused by laser hair reduction. And you should be very, very well versed on how to approach and treat the side effects in this patient. Patients forgive you if you are approachable and you manage their complications for them. So you got to be available for the patients for managing the side effects as well. And a good priming and absolute sun protection. Also, I've noticed that at least in the COVID pandemic, all our patients are going to be uh, a little well primed because they are off UVB radiation. At least they are not going out in the sun, so there is no sun damage to their skin. But many of them are really not using sunscreens at home, and they are not protecting themselves from high energy visible light. Dr. Rajan, can we do, has asked me, can we do a diode full face in one sitting? So if you're talking of diode laser hair reduction in one sitting, definitely you can do. But when we are doing the full face, you have to identify the hair diameter in the different part of the face. For example, if you're doing a case of hirsutism who has upper lip, chin, side block, and under chin thick hair growth of terminal hair, and you are going to do a full face where you also want to target the vellus hair on the nose and the forehead and the cheeks and the center of the upper lip, then your parameters for the laser should be changing. So when the hair is thick, your parameter is going to be different optimum energy with an optimum pulse duration. But when you're dealing with finer hair, your pulse duration has got to be a little low. And the energy will be based on the skin type. Dr. Sudhakar Rao, thank you so much. You've asked me a question. Fluence for blue red light in acne and carbon peel. So, blue and red light, it's a time based device. It's not a true laser. So it's a 513 and up to 500 to 600 nanometer wavelength. So the system which I have is a face mask which is worn to put on the patient. So patient wears the face mask, and the blue light and the red light is deposited alternatively for over next 15 minutes or so. As far as my parameters for acne are, I use in the gold toning mode. I will use a 5 hertz repetition rate. My system has a fixed spot size of 5 millimeter, and I use an energy between 0.35 to zero point 0.5. And I would do one or two passes, and I would like to target only the acne or the red zones of the face. In the carbon peel, I will use a 10 hertz, 10 millimeter spot size, and then energy of 1.2 to 1.4 on my patient. And this will be followed by a laser toning protocol where I would use a 10 millimeter or a 8 millimeter spot size with a 5 to 10 hertz repetition rate, and I would use an energy of uh, uh, 1 to 1.4. How to try titrate fluence in the hair removal. So suppose you started your first sitting, so if the hair is thick and robust and terminal and dark and pigmented hair, then suppose when I use a diode or laser, I use an energy between 22 to 26 depending on the skin type. If it's a darker skin, I would use a 22 fluence or 24 fluence. If the skin type is very fair, I can go up to 26 or 28. So depends on the color of the skin. And you can do a patch test to find out epidermal uptake and minimize side effects by running a patch test first. And in the subsequent session, you see how much is the reduction in the hair diameter. So if a terminal hair is replaced by nearly vellus hair, then your fluence can remain optimum. If it's a very fair skin, you can jack up the energy by 2 units, but your pulse duration must shorten. So thinner the hair, lesser the chromophore, the thermal relaxation time of the chromophore has decreased. So your pulse duration should be shorter. So remember, pulse duration runs hand in hand with the thermal relaxation time and the diameter of the chromophore. So, Omkar, I think with this we can wind up this session. This session. Uh, Hello. Yes, yes. Thank you so much. So, thank you very much for a patient listening, and I hope we managed to answer all the questions on your mind. Request you all to be safe, and we pray and hope we are able to get back into our normal life routine soon. Thank you very much.